All right. Well, good morning, everyone, and welcome to our Q&A live session this morning. This is a collaborative Q&A session on the Minnesota's Cost and Capacity Report, and it is brought to you this morning by our partners from University of Minnesota's Center for Public Health Systems and our panelists who are joining us from across the state, and of course, our MDH team from Public Health Practice Community Health Division. Uh, the order of business that we are going to go in is we are going to have a PowerPoint presentation from Jason Orr and his team, and basically discussing the findings and also the analysis of the cost and capacity report. And then we will transition into an overview of the statewide report and also our take from MDH, from Chelsea Huntley, our division director at Community Health Division. And then finally, we will move into our live Q&A session where we will have three of our panelists from different areas in the state who will be discussing their insight and their take on the cost and capacity report and how they have been using the live dashboards over the last few months and what their takes on the dashboard are. And then we will also have a period of question and answer. Please feel free to put questions in the chat and we will try to answer them as they come up within the hour. With that, I will pass it over to Jason, who will be introducing his team and doing an overview of the cost and capacity report for us. Thank you for everyone for joining us, and we're excited to have you here.
Yeah, perfect. Thank you very much. All right, so I will give a little bit of framing for the webinar today. I'll talk about the work that our team did in facilitating all of your health department's engagement in the public health cost and capacity assessment. I'll discuss how we approach the data, a little bit of how we analyze the data, and some of the top findings from our side in advance of the panel discussion on how different health departments have used these findings. So first and foremost, I want to say thank you to my team. We had a rather large team that worked on this project from start to finish. Each of the different staff members participated in delivering technical assistance to your health departments in analyzing the data and working on the report. So, it takes a village. So first, I'll overview the Minnesota Public Health Cost and Capacity Assessment. I'll discuss a little bit of the rationale and purpose for why we all did this work, and a little bit of framing and overview for the assessment itself. So at the direction of the Joint Leadership Team, we worked with different partners in the Minnesota public health system to design an assessment process to collect data on the current state of governmental public health services with respect to the foundational public health responsibilities. The aims that we were looking to identify were to what extent the local and state governmental public health system is fulfilling those agreed upon foundational public health responsibilities, which we'll discuss next. We were interested also in the human and financial resources being directed toward these foundational public health responsibilities. So how much staff time, how much, in direct costs were being put toward these services, really to identify, where there might be gaps, as well as where there were strengths across the system. And ultimately, we were looking to determine the investment that is currently being placed toward the foundational public health responsibilities, and to identify places where perhaps additional investment might be needed, or different trainings or things to patch up or shore up any gaps in the services that are delivered. So the foundational public health responsibilities, when we set forth with the assessment that you all participate in, we had a slightly different framework that was used. We used the the initial version of the Minnesota public or foundational public health responsibilities framework. Ultimately, though, the two crosswalk pretty well together. The FAB Foundational Public Health Services and the Minnesota Public Health Responsibilities. We feel that in spirit, both frameworks are in more or less in the same order. And the content and structure was pretty similar. So this more or less was the assessment that Minnesota participated in. We looked to understand the core infrastructure in place for governmental health departments, so these foundational capabilities, which are the cross-cutting services and infrastructure across all of governmental public health. So, assessment and surveillance, use of data is something that is found in each of the foundational areas or the programmatic divisions of governmental public health. So we were looking to understand the resources that are being directed toward your institutions and your functions and your high quality work that you deliver, as well as specific services that are delivered out into the communities through these foundational areas, which are, really where a lot of perceptions of governmental public health lie. So the framework that we'll be discussing throughout this presentation and later, follows these foundational public health responsibilities. So in terms of collecting and validating the data, all 74 of your local health departments and Minnesota Department of Health participate in the assessment. We aim to collect data from fiscal year 2021 and state fiscal year 2022 for the current human and financial resources and expertise and capacity with respect to the foundational public health responsibilities. And then also we asked health departments to estimate what they needed to fully implement each of the elements of the foundational public health responsibilities. Throughout the process, our center staff worked with health departments to improve data quality and confirm the final data. A lot of this was working with individual health departments to understand what challenges they had with figuring out how much of their time went to specific foundational public health responsibilities, as well as estimating what is needed to fully implement the foundational responsibilities. We recognize that this framework was new to many of the health departments, so these were not things that health departments were routinely thinking of. But our staff worked with most of your health departments to assure that the data quality was adequate and to answer questions about what data to include. Certain data elements were adjusted by us, mostly for when we wanted to combine multiple local health departments and the state health department together for the statewide findings. So for example, some of your health departments have the annual hours for one FTE being less than 2,080, which are 40 hours per week. So we needed to put all health departments on the same standard FTE to put them together. So those were adjusted. Certain financial data were adjusted for inflation. Each local health department and the state health department in particular have different fiscal years. Some were from January 1st to December 31st. Some were July 1st to June 30. So we wanted to make sure that when we were talking about the financial data for health departments, that we were looking at the same period of time. So we inflated these to 2022 real dollars. So we were all talking about the same amount of funds. And lastly, we did replace certain outliers with curve fit values. There were some health departments that you might have realistically or perhaps unrealistically estimated very high FTE or spending above their local health department counterparts, or much lower FTE or spending that were either delivered or needed. And in some places we adjusted certain outliers to the curve that we created, more or less so that we did not underestimate Minnesota needs in this assessment. For analysis and interpretation of the data, we self-assessed each health department's expertise and capacity to deliver the different elements of the foundational public health responsibilities. So to what extent was expertise or capacity available for each of these elements? And then we combine these into implementation scores, and that's most of what you see in those colorful charts that we have, which shows different intersections of capacity and expertise for health departments. We created charts and continuums to put these scores from the lowest possible scores to the highest possible scores, and created different zones for those charts from not implemented to substantially implemented. Lastly, human and financial resources, the FTE in dollars, were summarized and combined together for the foundational public health responsibilities. So we reported the current FTE and spending dedicated toward the foundational public health responsibilities. We reported the estimated resources to fully implement the foundational public health responsibilities. And then we identified the resource gaps between each. When I say plus contingency, that was what I mentioned on the previous slide, where we recognize that many of the estimates for full implementation needs were mostly focused on FTE that were needed and some contracts that were needed, but we also recognize that certain things were probably not captured. So for example, if your health department estimated that they needed 5 more FTE, you might not have also estimated that you needed, 5 more desks, 5 more chairs, 5 more, phones, the other expenditures needed to bring along additional staff, as well as HR time working to process those new hires and things like that. So we raised some of the estimates up, so we accounted for underestimation of resource needs. So I will briefly go over some of the findings. I know the panelists later will discuss how they've used the dashboards and some of the different findings, and there will be some other data that were displayed. As a high-level overview, we delivered with the joint leadership team and the advisory group that advised us on this process, findings for the state of Minnesota that identified specific strengths and weaknesses with respect to population health services delivered. We identified a baseline for measuring that your system's capacity over time. So, this point in time estimate that we did is, something that can be referred back to moving forward. And then we estimated the current and needed resources for the foundational public health responsibilities. So, when we talk about these population health services and recognize that all of your health departments deliver a wide variety of services, which of these services are more directed toward population health and what resources are being directed in that way. We will say that the assessment was not designed to compare health departments. This was not an exercise to set health departments apart or to compare the performance of health departments. Throughout the assessment, we explained to health departments through technical assistance and other means that these foundational public health responsibilities, if your health department had a very low level of delivery of the foundational public health responsibilities, that's not necessarily your fault. Your health department is delivering many services, using cooperative agreements and grants and other things that you're performing very well on. This assessment was meant to look at what population health services were or were not being delivered. That could be a function of lack of investment by governments. We did not use this assessment to evaluate the efficiency or effectiveness of health departments. Again, this was not to evaluate the performance of health departments. And we also did not include the full scope of all of the services that you deliver. again, our focus was on what was considered to be the foundational public health responsibilities, and not a lot of the individual and clinical services that each of you provide. At the highest level, this is where Minnesota health departments more or less lie when we bring together all of their self-assessed capacity and expertise scores across the entire foundational public health responsibilities framework. You can see that most of the data is skewed more to the upper right, so there's quite a bit more delivery there's been occurring, or a high level of expertise and capacity to deliver these services. This is more or less what we expected. Many health departments are delivering the population-based services to their highest extent possible. We did notice there's a fair amount of variation. You can see many agencies are fairly far apart. This data is important because we can identify specific gaps in potential resources, such as spending or staffing time, as well as to identify specific training opportunities. As you drill down through the data and the assessment, so if you look at the, say, activities tab of the dashboard or the headline responsibilities tab, that additional level of detail makes it a little bit easier for you to identify actionable steps for resolving specific gaps and moving forward as a system. When looking at the foundational capabilities in the foundational areas separately, you can see a little bit tighter grouping in the capabilities and a little bit better expertise and capacity. The foundational capabilities, again, are your infrastructure and skills and expertise that cross-cut across public health services. These are many aspects of routine operation of a health department, of communicating different messaging across different streams and things like that. So it shows that the expertise and capacity to do core infrastructure work, a lot of which is related to FAB accreditation, is fairly high across Minnesota. The foundational areas is where we saw a little bit more differentiation across health departments. We feel that this is very likely due to a lack of resources for those health departments to deliver. This doesn't necessarily say that they're not delivering foundational public health services, but just that they have low expertise or capacity available to them for many of the health departments in that lower left. Again, this shows where there could be some potential training opportunities. So, for example, health departments seem to do pretty well in communications, data analysis, things like that. But where there might be some specific needs are for specific foundational areas might need additional trainings for health departments in how to address certain population health issues or functions. And again, this can identify places to direct resources and effort. I'll show this slide right here. I know that many of you cannot read more or less anything that's on this slide, but I like to show this in presentations to really show the mosaic of delivery of these foundational public health services across the state. You can see going down the foundational public health responsibility framework and across health departments, starting with MDH and then those serving greater than 100,000 persons, all the way down to the health departments that are serving much smaller communities. You can see specific trends in perceived capacity and expertise to deliver services, across certain activities, or as we go from higher population served to lower population served. Again, this isn't comparing health departments on their ability to deliver or not. This is more of a representation of where there might be resource disparities or challenges in health departments' ability to locate and hire individuals that would be best suited to deliver these population health services, and really shows where there are opportunities for growth and partnerships and services and resource sharing for health departments. From a financial and effort side, these are the overall findings for the assessment. We found that the state and local system, currently spends a substantial amount of resources toward these foundational public health responsibilities, and puts quite a few individuals in those services. You can see that the spending per capita across the state really differs. There is quite a bit more spending in the foundational areas than in different areas of the foundational capabilities. Organizational management, not surprising, has a bit more spending, which is where a lot of the activities of the infrastructure activities for these population health services remain. In terms of the full implementation needs in the gap, health departments across the state identified substantial needs in additional human and financial resources for these. Interestingly, the distribution of spending is pretty similar for full implementation as it is to current implementation. So it's not necessarily showing that there are these huge gaps in specific services, but more or less additional resources are needed across the board, and this being the gap in resources. So before moving into the panel, we want to give a little bit of interpretation of the findings. Again, gaps were observed for certain capacity and expertise for certain services. Things like health equity and assessment and planning, which is where a lot of data and epidemiology lie, are where health departments across the state identify gaps. We feel that this is a great opportunity for training. There are likely not substantial financial resources that are needed to make improvements in these areas. And there might be a way to do some targeted sharing of staff to improve upon some of these gaps. We found that larger health departments tended to report higher capacity and expertise for services. This wasn't surprising to us. The larger health departments, more or less have the resources available to attract and recruit experienced staff and to focus more on population health services than the individual or clinical services. It was an opportunity for us to identify driving factors for where these capacity and expertise differences were, and to identify differences. And then lastly, there was some discordance between MDH and local health departments on perceived capacity and expertise. One in particular was the laboratory services portion. We do think that this is an opportunity for communication and education. Many for some of these activities or headline responsibilities that showed pretty drastic differences, might be more or less that the state takes on this function or certain functions and is delivering these services on behalf of the state. And this could be an opportunity for a better understanding of the services that the state is delivering on your behalf, and also vice versa. The state is substantially involved across your local health departments in supporting different cooperative agreements and state funds, but there are opportunities for better information sharing between health departments and shared understanding and what each of you might be delivering in each of the different communities. Lastly, we want to acknowledge the Public Health Accreditation Board, the Robert Wood Johnson Foundation, the Minnesota Department of Health and the state of Minnesota, and then the joint leadership team and advisory group in all of this work. Really everyone worked together on this assessment, and we feel that it came out pretty well. So thank you very much for allowing me to speak, and I will let you move on to the panel.
Thank you, Jason. I just wanted to actually mention that we will be taking all of the questions that come up in the chat at the end of the panel discussion. I will pass it on now to Chelsea Huntley, our division director from Community Health, who will give us an overview of the state and how we have been using the data internally. Chelsea?
Awesome. Thanks, Ghazaleh. Thanks for that, Jason, to remind us all about the assessment. So I'm going to be fairly quick. While I've done some time and played with the dashboards from a statewide perspective, I still really find the patchwork the most helpful tool. Part of it is just how my brain works. But also part of it is like who I'm talking to and what the message is we're trying to say. So like when I look at the patchwork, it really shows what you've all been saying and we've all been feeling for many years, right? Like there is just wide variation that no one has, right? What they need to do all of the things, that we have some great areas of strength. And we have some places where like collectively we need to do better. So for me, this picture really displays that. For those of you who were here kind of pre-COVID times, you know, pre-COVID, I really loved the red, yellow, green bars. Like that was a useful tool to tell the story. And now like, I think this gives us even more depth to that story to really talk about. You know, what is the state of our system? And I look forward to seeing like more and more dark colors populate this patchwork as you all figure out how to leverage new funding and new partnerships, and MDH works with you to clarify roles and responsibilities and all of those pieces. So I still use this a lot. I do want to give just a nod to some of the things that Jason said in terms of there are places here that like we get to be really curious, like why is it that there's some things where you know, MDH feels like it's fully implemented and many local health departments don't, right? Like what's the opportunity there for greater communication and sharing? Why is it that we have gaps related to equity and policy development, et cetera, right? In addition to more funding and resources, what else is getting in the way of those pieces, right? So I just see it as like a great visual to tell the story and then get really curious together. When we go to the statewide dashboard, for me, it's kind of going that level deeper. From a statewide perspective, the icicle isn't super helpful because it's just like all light purple, right? But if we go here and start to scroll down through the capabilities and area, right, we can see where we're skewed farther to the left, right? And try to figure out, okay, if the system overall is skewed greater to the left in what is this, data and epi, right? Like that's a place where we can try to figure out statewide where to spread. So for me, this one gives like the next dive from the icicle chart that's super helpful. MDH is a state agency. I will be honest, we haven't dove into these dashboards by individual divisions or programs yet, but certainly the assessment process helped us begin those conversations, like it helped you all begin those conversations to say, oh, environmental health, well, we're like the regulatory stuff we're good at, like that's pretty concrete, we can wrap our hands around, but like, oh, the planning stuff, we're not really structured or built for that, right? So I think still in the earlier phases of those conversations and in the earlier phases of seeing patterns across the agency in terms of if policy development is a stretch for all of the divisions, how might we build that up? So anyway, that's my kind of short and sweet version. I love the patchwork. And then for me, like this statewide view of the capabilities and areas is most helpful. I'm eager to hear from some of our local health departments, how they're using this information.
Thank you, Chelsea, for that overview. And I must say, like, I still find the cost and capacity report fascinating, and I have been with the division for less than a year, and I'm still digging in and trying to figure it all out. So there is a lot of information in there and a lot that can be beneficial to all of us. With that, we are going to move on to our panelists who have graciously agreed to present their point of view, actually, and also providing us with how they have been utilizing the cost and capacity dashboards in order to report back to their administrators, their local officials. And with that, I will do a quick representation, a quick introduction, excuse me, and also move us on. Our panelists have agreed that they were provided a few questions and they will each respond to those. And then we will move to the next person. With that, our panelists are Marley Morrison from community. She is the community health director at St. Joseph's Health, so a hospital-based CHB within our state. Then we have Sarah Benson, who is the director of Renville County Public Health, and she is also the CHS administrator for Candahoy Renville Community Health Board, so a multi-county health board. And then we have Sarah Broches, who is the Wright County Public Health Director, so a single CHB, standalone CHB. With that, I will pass it on to Marley, who will share her insight with us, and we'll move to Sarah and Sarah Benson, and then we go to Sarah Broches. Thank you, Marley.
Okay. Hi, everybody. Again, my name is Marley Morrison. I am the Community Health Director for CHI St. Joseph's in Park Rapids, Minnesota. We're one of 5 hospital-based public health agencies in the state, and they're all in the Northwest region. So we are the public health agency for Hubbard County, and we also are part of the North Country CHB, which is Hubbard, Clearwater, and Lake of the Woods counties. Lake of the Woods also being a hospital-based public health agency. And I participated in the work group after I obviously did blood, sweat, and tears to complete the cost and capacity assessment like you all did. And I then was fortunate enough to be on the group, the kind of work group on this. So you would think that I would be very expert, and I'm going to just tell you right now that I still find this very dense and very kind of difficult to wade through. I agree with Chelsea. What I have found the most helpful, at least at this point, is still just the mosaic that Jason showed us, because I think that really just lays out, and I also think it really helps show our smaller agencies. So we are hospital based, but I'm also representing a county of 22,000 people. So it's helpful to see where we line up. I also in the key findings report, there's some state photos or whatever that show comparisons by county, by color, and it always is very soothing to me to see how many surrounding counties to me are similar colored. And I know Jason said that this was not done to compare or contrast our abilities, but I think I would guess that many other people feel the same as I do, where you feel a little bit like you want to show what you're able to do, even though you are a small county. So that being said, we pretty much hit the middle of partially implemented on a lot of things. I've been messing around with a lot of our trying to see, like, especially with where we fall in those little graphs. I have not shared that with decision makers because my feeling on it is that's pretty dense and esoteric and would require, I'm not sure in the amount of time that I would have with leaders, I could convey what I'm trying to convey yet. I need to work through it a little bit more. So that's always, like, I think for all of us, especially in a small county, and especially me, I have limited time with our commissioners because I am hospital based. We contract with them, they trust us to do our work. And so I just give updates. So and we don't receive any tax levy dollars. So it is, we're walking that fine line a little bit there. So again, I like the broader overviews right now. And I think the place where to really delve into it perhaps is at our CHB a little bit more. And I think I can work with our CHB administrator on how we want to present that. So that's kind of the first question, is what we're looking for. And I'm going to kind of jump ahead to where the data is pointing in the next logical steps, because I think for me, so there's 2 things we have here. When we're hospital based, we also, in addition to doing our CHIP plan as a CHB, we also have every 3-year community health needs assessments that I complete for our hospital. And that actually is coming due again in 2025. They come by so fast when they're every 3 years. So my hope, and prayer here is to somehow utilize this and put it into there and make a little more of a robust CHNA. Because again, with all of these things, I think this is my biggest struggle a lot of times when we're doing these more large overview or big pictures and policies. How does all this information actually improve the lives of those people who are living in my community? And how, I mean, I can show this graph and I'd be like, great, like, you know, we still can't, there's only one bus in the whole county. So how does that help me? So how do we use this to also fully improve lives? I haven't answered that question. And I think the other thing too, and then just to segue into, I'm not going to answer the question about my trends seen at the statewide or regional level. I do not have that answer, but the gaps in FTE and spending. So we always feel short-staffed. And I know one thing when I was filling it out and I was working with my other directors in our CHB was that we're answering all these questions. It's like all the questions are the director. The director is like pieced out into like a million little pieces to complete this work. And because we have staff, I have a staff of 10 and they are absolutely busy doing direct service. So where this is where I think needs more. How do we use this funding to fill in those gaps? Do we just need a public health planner? I mean, that's the easy answer. But I also appreciated that Jason mentioned, because this is something that I had written down too, was, okay, I want hire another person with my money. I have zero room in our office to add another person. I mean, I already have people bunked together in offices. So there's just these logistical things too. It can get really overwhelming, but I'm trying to stay focused on how can I use this data to improve the lives of those who live in Hubbard County and North Country CHB. So I think that was all I have to say for right now.
Thank you, Marley. I do appreciate all of the insight. And next, can we go to Sarah Benson, please? Thank you, Sarah.
Hi, everybody. Good morning. Sarah Benson. I am Director for Renville County Public Health and then CHS Administrator for Candy Ohio Renville CHB. Just a little background history, kind of like what Marley did, is Renville County, we are a population of 14,500. And then on the contrast, Candy Ohio County is 43,800 estimates. So we are that multi-county community health board where we are operating very much independently, but we also have overlap and receive our funding together. So some of our uniqueness has come in, we have to look at we're looking at that patchwork. We're in two different areas on the patchwork for our counties. So pulling those together has been a little unique. I was also part of that cost and capacity advisory committee, like Marley had mentioned. And yes, I still do not fully understand every single little part of it because it is big. As I look back time and time again on the dashboard results and start to think more intentionally of this, because I'll be honest, prior to doing the cost and capacity assessment, I did not intentionally look at foundational public health responsibilities as much as I should have probably. So as we're spending more time on it, learning more about it, I can honestly say even over the last years, since doing the assessment, that some of my thoughts on the answers and things would have changed. And that's okay. It's okay to do that. Like Jason said, we're spending a lot of discovery of the public health system's strengths and weaknesses. And, it's just an estimation of current and needed resources. And as Chelsea said, this is giving us an opportunity to explore our curiosity more into these areas. So Linda has just a screenshot of one thing that I've kind of done a little bit. If you're able to share that. What I like to kind of do sometimes is pull up, I have dual screens. So sometimes if I'm in the office, I can pull up dual screens, or I just shrink my screens down a little bit. And I like to spend some time comparing sometimes. So if I pull up on the one side, I can pull up, my implementation of foundational public health responsibilities. And then on my other side, I can go through and pick different areas. Like here, I picked the FTE bars where I can go through and compare the two areas that way. It's just an easier view to see everything all at once. So that's worked well for me in comparing a couple things at the same time. These are a couple of the things that I have used to share with other people, to share with our community health board. They seem to be a little bit more clear in a way. When you start getting into the curves and everything, I feel like I've needed to explain a little bit more. It's harder for some other people to understand sometimes, or all those little dots, that are on our square things as well. So This has been easier for some of our stakeholders to understand. It's also, it doesn't have you, some of the pieces when you put it in, it almost makes them want to start comparing. You know, this isn't meant to compare each other, and some of those other graphs, I would personally use my own caution in using some of those with stakeholders, because I have a feeling that they have the tendency to start comparing just when they see those other things. Again, that's just the feel that I've gotten. Maybe it's not in every area, but again, it was a self-assessment, so there is subjectivity in it. Since we've done it, it's given me reasons to think more about why we marked some areas the way we did, and also thinking forward, can we strengthen some areas with our current staff and education to increase our expertise rather than adding FTE? There's some areas, you know, that could definitely be done with that. For us, for example, health equity. We probably don't need to add like 1 FTE or something just to focus on health equity. We probably intentionally need to go through some strategic planning and workforce development to make sure that our staff are all well versed in health equity. Are our policies and programs being provided equitably? There's different ways that you can look at doing it and being more intentional with it without having to add staff. So just spending a lot of time looking at those areas. In our region, on the statewide dashboard, there is a few areas where you can look at the different regions. So we're able to look at that a little bit. And one thing that our Region 6 is doing is we've kind of found that all of us are a little bit light in the data area. So the data expertise and FTE, and we are exploring different ways that as our region, we maybe don't all need 1 FTE data or a partial FTE data, but is there a way that we can share a resource? Does somebody already currently have a resource that we can lean upon if we can increase their capacity some way? Can we contract something together? So just looking at things differently that way. Yeah, I think that's a higher level overview of what we've been doing with Little Bit. We did hire a public health planner across our community health board with some of this data. We used some of the things out of this cost and capacity to share with our stakeholders in order to get that position passed. So right now, if we did our cost and capacity assessment again, we would definitely be higher in some areas like assessment and planning and community partnerships and some of that data, because our public health planner has some of those roles. And now we're looking at it in other ways of how can we use this data to support if we need other positions.
Sarah, would you like me to show how to focus in on one region?
Sure, yeah. It's on that statewide dashboard. So there's 2 different dashboards. You have your agency level and your statewide level. So if you go into the statewide level here, where Linda's showing for headline responsibilities example, you can choose, instead of choosing, yep, there you go. So you can see across the top there, those comparison groups. You have Minnesota Department of Health, and then you have each of the different regions. So region 1, 2, 3, 4. And then on the left side there is your capability or area that you're looking to compare. Yep, and then she's showing how you can do a keep only, and then you can kind of show just like our Region 6 right now. So with that, I will pass it on to Sarah. Thank you.
Thanks, Sarah and Marley and Chelsea. This is Sarah Grotius. I'm the Public Health Director in Wright County. And I'm just going to talk about a little bit about how we use the cost and capacity information and made some decisions. We actually used a lot of the points from the assessment to facilitate a conversation with a work group of board members and community members around a particular area. I'm going to have Linda pull up the icicle chart for Wright County. So we didn't actually have this available to us at the time, but you can see that peachy and yellowy block, that's for environmental health. So that foundational area, and as well as the headline responsibility. And one of the headline responsibilities that is peach or yellow, I guess, is conduct the mandated environmental health, yes. Hold on, I want to make sure I'm saying the right one. I want to make, Linda, can you highlight it for me? It's the local laws and regulations one, right?
This is a screenshot. Let me go to the actual dashboard.
Oh, well, I'm pretty sure it is. So I know that we kind of Linda and I had a conversation back and forth about how that was like some people reported that as fully met because MDH does that, but I actually at the time did not report that, not because MDH doesn't do food pools and lodging, but because we have a local ordinance for public health nuisances and we did not have staff in 2021. We lost our staff. And so I was filling that role as the only person really who could manage that. Supervisors was still responding to COVID. And so I was filling in gaps as someone who felt comfortable filling that role and completing the processes. I have done that in the past. And I happen to have a background in a degree in biology, so I felt pretty comfortable doing that in previous roles, but that is not how we operate necessarily in our county. It's not an expectation for a manager to be operating a program. And to me, that was really emblematic of the weakness in our system that we could lose a staff member and have absolutely no ability to implement a program that is foundational on our system. So after some conversation with board where we talked about the need to have staff for this particular area, that it is an ordinance. We worked with Julie Ashley, who's a systems consultant who's since retired, and used the foundational capability measures that were asked. We didn't, again, have the icicle chart, but went through and evaluated against our system that we currently have, both the MDH system, but also the system we have. And we had our planning and zoning director there, as well as different parts of our county administration and 2 county board members work through this with our county attorney, kind of say, here's what we have, here's what we don't have. And we did it over a course of 2 meetings, 2 longer half-day meetings. And kind of go through and we came up with 3 priorities from that and devised a work plan. The first was that we wanted to have a streamlined complaint process for environmental health. So it's very confusing. I don't know if anybody has encountered this, if you work in this area at all at your local, but nobody really knows where to submit a complaint or what type of complaint goes where. So is it a planning and zoning complaint? Is it a public health nuisance? Does it go to MDH because it happened at a restaurant? Does it go to Department of Agriculture because it happened at a grocery store? Does it go to the health department? Or does it go to, does it go to me? And we just worked through a process of that's just not very fair to the general public. They don't need to know how the sausage is made by calling somebody and going, oh no, you have to call somewhere else. And oh no, you have to call somewhere else, right? That's not good customer service. And it's really not helping our environmental health system because what people are just not going to tell us what's wrong. So that was the first priority. And then we also, we're going to work through the development of a water lab as part of that. That was something that had been a goal. It has a 2-pronged process. It helps support our development and support of our licensed childcare and adult licensed care homes for through our human services department, because if they're on private well systems, they have to have yearly nitrate and bacteria testing. And we had been providing that, but not, the county had been providing that through a partnership, but not through the correct means. Let's just say we had to clean up a process. These are all the things you find out when you start delving into. I love how Chelsea's laughing. So we were just, and we inherited some processes, and we're working through making that an accredited lab. We have no accredited lab in a county with 150,000 people. And so that, that really fits under another piece of this environmental health part, which is ensuring that there is also drinking water protection. And that has actually been a very hot topic for a lot of, not hot, but like a hot service. Like a lot of people want to partner with us, which has been a great, because we haven't been involved in a lot of those planning pieces, which is the other yellow bar on there, which I think was a weak area. A lot of us were really like, and I think Chelsea even mentioned, people were doing those mandated services, but not doing that planning and prevention piece, or not having staff capacity. Even when we had great follow-up for nuisances, the staff didn't have staff time to be at soil and water meetings and connecting with planning and zoning directors. And so we were able to increase that FTE to really provide the ability to do that coordination. And so we're writing grants together and supporting each other, and it's really been able to grow just with having, and it wasn't an addition of a whole FTE, it was already a partial position. We added, I think, 0.5 FTE to make it a 1 FTE position, and it was quite advantageous to us. We accepted some work from planning and zoning, but it's been a lot of times it turns out they get like 7 times the number of complaints that we get. So it's really been fortuitous. Another really interesting example is we recently worked a failed septic system together. They had sent multiple letters, but it wasn't until we filed it under our ordinance and sent them the health nuisance that the property owner responded. So you never know what lever works. So it was really helpful to use the framework and the questions to work through the process. And we used those standards of kind of expectations in the context of the board. But I don't know, I would agree with folks. I don't know if I would bring this entire chart to a full board, but I think taking it chunk by chunk is a better way of doing it. So when you do it with environmental health, there are 6 questions under there, and comparing it to your system and kind of evaluating it was an easier way to do it. In that case, we were really trying to dig into something, and I'm sure most of you who had to answer these were aware that, you kind of knew where your trouble spots were. Our next steps for us are looking at, we're going through our strategic planning processes. So we're trying to align this with our other work. And, I think it's prioritizing what we can do. We have some other, cost and capacity is just one piece. We have all sorts of other things going on, as many other counties do, that you have to take in all those different pieces of information to decide what the next logical step is. Thanks.
Thank you, Sarah. We had a couple of questions come in through the chat, and I would like to open it up. I think the first question, Jason had answered it already in the chat. And there is another question: will there be more training on how to use, navigate, interpret the online dashboards? And I think, Chelsea, you mentioned a little bit about that, and the further dive that we are doing into the data. Do you want to say anything more about that?
I'm going to actually pitch it to Linda, who might know more about what's on the website and recorded for training and what else might be planned. Sorry, Linda.
No, that's fine. Actually, I see Melinda has popped on. She's with the University of Minnesota team, and she is really the brainchild of those videos that are now on the MDH website. Melinda, do you want to mention something about those videos?
Sure. I believe our team has made a series of videos that kind of explain how to basic navigation and how to interpret the data. So I think they're pretty much all ready. I'm not sure if they're already up on the webpage or not, but they should be shortly. And hopefully that can help be an on-demand resource for using the dashboards. And I just want to say thank you so much for sharing how you're using them. That's so cool to hear. So thank you very much.
Excellent. And I just want to mention that You'll see in the chat some links to the MDH website and the University of Minnesota website that sort of mirror each other with content related to the results and how to navigate the dashboards and links to the dashboards.
I see there is a couple of links for the dashboards and also the videos in the chat. And I don't see any other questions. Are there any other questions? If
That's what we do have the question from Damone, correlation between core capacity, capability, and accreditation and YPLL, life expectancy. I certainly don't have the answer to that, but I'm wondering if maybe somebody from the University of Minnesota team might have some insight.
I think that was the one that I referenced that Jason had responded in the, but if you want to take it, Jason, go ahead.
Yeah, I think it's a really good question. So, I mean, it's not something that we did through the work that we did for the assessment to look deeper into, how the findings from the assessment relate to, other data that we have for the Minnesota public health system, both, the health factors like, what things lead to different health outcomes, as well as the health outcomes themselves. I do think that it's very likely that we could find associations between the two. I don't know necessarily if the findings from this assessment can, like, if there can be a causal link between, okay, you're not doing this, so this means that this, health outcome is like this. In reality, many of the population health outcomes that we look at in public health are things that aren't really acute, not necessarily something that happened immediately because something wasn't there, but chronic conditions, years of potential life lost, and things like that. But say looking at the maternal and child health portion and seeing what population health services are delivered or not delivered, we know that there's a relationship between the years of potential life lost and infant mortality. So that could be a place to look. I do think that this assessment gives a variety of avenues to dig in deeper. But to our knowledge, there really haven't been any studies that are looking at the foundational public health services themselves as a whole and specific health outcomes.
Thank you, Jason. With that, we are up at the hour, and I don't see any other questions. So I would like to once again thank our panelists and also our University of Minnesota partners and Chelsea for joining us. We do appreciate everything that you have done. And hopefully we will have further conversations about the dashboards and keep using the data. Thank you, everyone.